Hello, my name is Taylor Thompson, and today is September 17th, 2024. Today I will be talking about ectopic pregnancies. So, pregnancy begins with a fertilized egg. Normally, the fertilized egg attaches to the lining of the uterus. As depicted here on this left image, we have our ovary, fallopian tube, uterus, and as we can see, our fertilized egg attaches to the uterine lining. An ectopic pregnancy occurs when a fertilized egg implants and grows outside of the main cavity of the uterus. So this can occur in the fallopian tube. This is most common. The ovary, abdominal cavity, or the cervix. So this other photo shows again our ovary, fallopian tube, uterus, and as we can see, our fertilized egg is stuck in the fallopian tube and therefore did not make it to the uterus. And so this is considered an ectopic pregnancy. I said stuck in or implanted in the fallopian tube. How does this happen? In hormonal complications. So typically a fertilized egg can become stuck in the fallopian tube due to damage from whether it be inflammation, scar tissue, misshapen fallopian tube, STIs, smoking, multiple sex partners, in vitro fertilization, also known as IVF, previous ectopic pregnancies, and infertility. This is not a complete list by any means, and there are other factors that can play into an ectopic pregnancy. A fertilized egg can also become ectopic due to hormonal imbalances or abnormal development of the fertilized egg. Some of our hormones that are affected is an increase in progesterone. They've also seen an increase and decrease in estrogen, and more often than not, an increase in the human chorionic gonadotropin. Treatment. So an ectopic pregnancy is life-threatening and is a medical emergency. This is the leading cause of maternal mortality within the first 3 months of pregnancy, and typically untreated leaves the patient bleeding out if where the fertilized egg implanted bursts. Our treatment options are surgery, and this is typically for ruptured fallopian tubes. Our other treatment options are medication, and this ultimately terminates or ends the pregnancy. The drug typically chosen is methotrexate. I'm sorry if I mispronounced that. This stops a fertilized egg from growing and keeping the fallopian tubes from rupturing. It cannot be used during breastfeeding, so that is something to keep in mind when prescribing this to somebody who has an ectopic pregnancy. Risks with taking this include nausea, vomiting, abdominal pain, vaginal bleeding or spotting, diarrhea, and dizziness. The risk of a fallopian tube rupture does not go away until the treatment with methotrexate is complete, and this is because if the fetus or if the fertilized egg grows any larger, it could burst the fallopian tube or wherever it is located, because where it's implanted isn't made to sustain life and allow life to grow there, and therefore can rupture where it's implanted. So what I looked at was a case study, and so I'll show this case study real quick. So that's from the National Library of Medicine. It's called Ectopic Pregnancy in an Adolescent, Case Report and Review of Literature. And pretty much what this shows, sorry, one second. From current slide. So to determine an ectopic pregnancy, many factors are considered, and the main factor typically is human chorionic gonadotropin, so HCG. So in this case study, they were presented with a 17-year-old patient who was having abdominal pain and vaginal spotting at an ER hospital. Upon her history showed that She has one monogamous partner, no smoking, no STIs, no IUD, and no previous pelvic surgeries. And her previous history showed that a couple days prior, she had an HCG level of 4,788. And then 24 hours later, her levels dropped to 2,144. The American College of Obstetricians and Gynecologists recommend an HCG over 3,500 to avoid misdiagnosis. So pretty much the American College of Obstetricians and Gynecologists say that when diagnosing ectopic pregnancies and you're looking at HCG, they recommend that it should be over 3,500 so that you are not misdiagnosing. Upon presentation, her HCG was 1,600, but using ultrasound in conjunction, they determined that it was an ectopic pregnancy, and they found that it had implanted in the fallopian tube. So this case study looked at how we should not solely rely on HCG levels, and it also goes over the history of HCG levels in the past, and how it's once was at 1,600, then raised up to 2,200, and now is recommended above 3,500 so that there is no misdiagnosis. But they're recommending that you use this in conjunction with ultrasound, pathohistology, and a patient's history to guarantee that you're not terminating a pregnancy that is not ectopic. So this is my presentation, and thank you.